और bubbles के लिए जैसे हाँ तो नीचे को point could be you shake it ताकि bubbles ऊपर आ जाए and then now you can section it. Okay. चल हाँ जी सर और अब एक्सटेंड करें बिग व्यू एक्सटेंड गुड अल्ट्रासाउंड भी दिखा दें Yeah.
Mustafa, we are with you.
Okay.
Can we have the case, please?
Yeah. Okay, good.
Can we present the
Are we
case?
audible?
Yeah, they're about son. You go ahead and present the case.
Yes. Assalamu alaikum, are we audible?
Yes, you are.
Okay, sir. So I'm Dr. Aswasin. I'm going to present the case. This is a 26 years old male with history of chronic pancreatitis since 10 years. He was asymptomatic around 2 years. After around 2 years back, he had a pancreatitis episode, and now around 2 months back. At that time, he was investigated further and found to have elevated IGG4 of 3880, that is around 1.5 times the upper normal limit. Along with it, recent MRCP was done, which was showing
Keep turning.
with suspected pancreatitis, suspected pancreatic
That's
divism.
the vertebrae.
There
You see
was a
that's the
stricture in the
bones.
pancreatic
So keep going
head, followed by
clockwise.
ERCP, which
Keep going
confirmed the
clockwise.
diagnosis of pancreatic divism plus
There you go.
stricture. A stent was placed in June.
And you
Currently,
may
is here for
pull
endoscopic
back
ultrasound evaluation of
unintentionally,
chronic
so you may have to go in a
pancreatitis.
tiny
And the
bit.
stent is through the minor papilla?
Yes, sir.
Okay.
Yeah, so let's just reset, go back into the.
Off.
So we're just at the G junction, and so look endoscopically, make sure you know where you are. And so we're still, so look, find your lumen endoscopically, okay? So go ahead and drop your left hand. So go counterclockwise. Counterclockwise. Keep going counterclockwise. There you go. Now advance a tiny bit. It's okay. You there. Stop. Okay. Now you can go suction. Big wheel towards you. So big wheel up. And go clockwise. And you can pull back a tiny bit if you want. Okay, right there. Now keep going clockwise. Good. Keep going. Keep going. And there's your aorta, right? So I just want to highlight this. Sometimes, if you could show us the endoscopic view just by going counterclockwise. So go counterclockwise.
Yeah.
Keep going, keep going. Show us the stomach for a second. Up. Can you see the endo view? Yes. So show me the stomach. I want to see the. So sometimes what happens is, pull back a tiny bit. If you start, let me take over just for a second to demonstrate this. If you sometimes come right at the esophagus, you push forward, and you stop here, sometimes as you go like this, you may have a hard time advancing the scope. You're getting stuck. Here I actually didn't, but when you were doing it earlier. So it's always better to just reassess. Don't keep pushing forward because you can get trauma. You gently advance the scope a centimeter or two. You know that you're past where you really want to be. Now you can suction. You make your big wheel come towards you, and you go clockwise. And if you feel that I'm too far forward based on the portal vein, You can always pull back with a bit of big wheel towards you and then keep going clockwise for your aorta. So you don't have to force anything at the G junction. It's okay to go slightly ahead of yourself and then pull back as well.
Right.
Okay? So I'm going to hand it back to you because this is where you were. So take over.
Yeah, so this is a very important point, Mustafa, thank you. Because the way I was telling everybody, find that celiac axis, a cement, and go move forward, but scope sometimes
So
gets hung
I'm
up
at the
there
celiac axis
because
now.
of
And
idle
this is the
hernia
celiac.
Just give me
or
one
the
sec.
shape
He's
of the
speaking.
stomach. In
sorry.
those cases, just go beyond the G
Idhar volume
junction
unchi
into the
kar rahe hain, we
stomach
can't hear
and
him.
then come
I
backwards.
use the below.
Okay.
And also just imagine that you are in the stomach, one
Yep,
side
good.
is going to be pancreas, other side is going to be liver. So you have, if you're just seeing a liver at the bottom, you have to rotate the
So
scope
now-
to go to the pancreas.
That's the pancreas.
Because pancreas is
Yeah,
at the bottom,
that's
right?
dark looking
Inferior,
pancreas
and liver
with
is on the
the
bottom side.
slightly prominent PD in the center.
Good.
So I'll keep chasing the PD now.
Yeah,
The
we're not
big-
chasing it, we're following it, right?
Yeah.
So go counter. Okay, good. Now pull back on it a bit. There, and keep going clockwise. Good. So a lot of abnormal parenchyma here. Keep
Yeah.
pulling back.
Okay.
So just for the audience, I'm going to put the flow on.
It is varices in the splenic hilum or just
We
normal
can come back to
vasculature?
that, but
Yeah.
I will come back to that. Just
Yeah.
show me the pancreas. So if it's
Yeah,
if it's to the left, what do you do with your scope?
I move it counterclockwise and oh sorry, I just push in a bit.
Yes, good.
so
You
that
relax
it's in
your
the
big wheel a
center.
tiny bit and push in.
Yeah.
There you go. Now find us the pancreas again, and go clockwise.
So that's
Yep. So
pancreas.
keep it in view and keep going clockwise till you lose it. So now when it goes down,
Down.
you have to slightly big wheel towards you, and keep going big wheel towards you to keep it in view, and keep going clockwise. So you
Yeah.
right about there you lose it. So you bring up a good point about potentially there being. What's the difference between varices and collaterals?
Varices are the result of portal hypertension basically, and
What are collaterals?
collaterals are smaller vessels that develop around a blocked vessel.
Okay, so varices and collaterals are the same thing depending on where you see them.
Okay.
Anything that is intraluminal that you see submucosal, that's a varix,
Okay.
whether that's gastric or esophageal. Anything that is outside, behind the mucosa, or outside the organ, outside the gastric wall, in the perisplenic region, that would be a collateral vessel.
All right.
So even on the CT, you will see a lot of collaterals, and sometimes you'll see the fullness in the fundus, and that's your varices. But they're the same thing. It's all about the definition is based on the location, intraluminal versus extraluminal.
Extraluminal,
Okay.
right.
So what you're seeing are not varices necessarily. You're seeing collaterals.
Collaterals,
Okay.
right.
But this is also a good time when you see that to consider doing a retroflexion endoscopically to see whether or not you see varices as well. Okay, so go ahead and let me just show us go back towards the splenic hilum, and let's just see. The other thing we can do here is you know that you have pancreas, right? So pull back, show us the splenic vessels here. So pull back where you would expect to see the splenic vessels.
Yeah.
Okay, good. Now go counterclockwise. So stay on the spleen. Sorry, on the pancreas for a second. One thing is, like, if you see something like this, you could, I guess my point is that what we want to do is look at the Doppler flow. Doppler इस वाली machine में कहाँ से होगा? नहीं, जो वो तो on करें, and I want the waveform.
B mode. Pulse wave.
Pulse wave. There you go. What you can do is, if you suspect a vessel to be a varix, you could put this on and see. So it's a moving target. Stay in one place.
Okay,
Try not to move
alright.
this, because if you move the scope, then I can't measure it, right?
Sorry.
No, no,
I'll
you're
st-
fine.
I'll stay here.
Yeah. So what is this?
Arterial most like.
Yeah. So which artery?
Splenic.
Good. Keep going clockwise for a sec. Firstly, if you see splenic artery, the next thing is if that's pancreas, we would expect go counterclockwise for a second. Keep going counter where you would expect to see your
It's all right.
This is it's okay. You're fine. Let me take over just for a second
Yeah.
to demonstrate this. Right. I think your point about the collaterals is valid, but let's see. We have pancreas here. There's our PD. If we would expect to see the splenic vein above or below the pancreas, above or below the splenic artery. Splenic vein.
Above the
What's closer, artery or vein?
closer is basically vein and
Artery is
artery.
closer.
Okay.
Yes. So you would expect to see the vein here. You see this big vessel, but you see a smaller vessel underneath, which you're not making an obvious. You don't see those two classic vessels, right? So I think your suspicion is high. So as you were doing, you could go towards the hilum here, and you do see these multiple vessels. Whenever you see this kind of an image, you're absolutely on the right track. That could there be splenic vein occlusion, right? And what you can do, similar to what we were doing earlier, now we can put the power wave form on here and see what we see. And all we see is like, it's not a complete flat waveform, but part of it's because of the movement with the breathing, but it's for the most part flat, right? So I think you're absolutely right. That's a good pickup on your part, that this is likely splenic vein occlusion with collateral vessels. Okay, and this we can try here. This is one big vessel, so we'll do a floor here. It's okay to take your time on these things and study them. There's no rush to like complete your exam, because this is why this patient's here. And look at this. This is your classic flat waveform. When the breathing is stable, you can see that that's a flat waveform towards the right of the screen, and that's your venous. Exactly. So yes, we expect this patient has splenic vein occlusion, and we are seeing collateral vessels.
Okay.
Okay. So now,
Moving on to duodenum.
yes, go ahead and move on. I think you could see the duct. You could try and follow it to go further down towards the neck, but it's okay for now. In the interest of time, why don't we do the duodenal exam?
Yeah.
So what is the purpose of this exam? Just for evaluation of pancreatitis? So one of the questions here would be, whether or not to biopsy if the...
Mustafa,
Yes.
the purpose of this particular case was that, we are seeing more and more patients being treated as autoimmune pancreatitis with no EUS examination, with just an elevated IgG4.
Yeah.
And what we wanted to show was that, and also in the clinical setting of chronic pancreatitis.
That's good.
So if a patient comes with chronic pancreatitis, has a high IgG4, is just diagnosed as AIP, and then they've started treatment as well. So we wanted to bring this case and show you that that's always not true.
Absolutely. I think the IgG4 being 1.5 times the upper limit is not a at all diagnostic of autoimmune pancreatitis. This is a young patient with divisum and also younger at age, so you have to think of hereditary pancreatitis, and unfortunately we don't have genetic testing, but that would be a consideration in a young patient before starting somebody on steroids for a very minimally elevated IgG4. In the meantime, you were doing well. You had the duct, right?
Yes,
So
I
let's
had.
get back to that position. So, okay, so what do we
That's
see here? You want to
Portal
point?
conference going across this. And
Okay.
I think this. I'm
Here,
a bit
let me-
too.
What is
uh,
this?
This seems like a vascular. No, this.
It
is a
seems like it, but Doppler shows what?
I'm trying to release, but when I release it, it just.
So you can put your balloon up a tiny bit. That'll
Oh,
help you
yes.
sometimes in these situations. Just a tiny bit. Now suction.
Yeah.
Okay, we're gonna get rid of the Doppler for a second. There's a lot of air in the balloon. That's why you got this. So we checked our balloon, but
Yes, we did.
yeah, go ahead and advance the scope again.
Okay. I lost the contact somehow.
Yeah, pull back
so-
because you have air in the balloon area now.
Yeah.
So pull back, put the balloon up. No, before you go in. No,
Yeah,
come back,
so,
come
okay.
back. Put your
Right.
balloon up. Okay, there's water. Now suction, push all the way down on your suction button. All the way down.
All the way down. Right.
Okay. Okay, suction the scope. Okay, good. Now go, pull back and look where you are, and then go back into the duodenal bulb. We'll try this one more time. So
Okay.
pull back. Again, reset.
Yeah.
We're not sure where we are, you pull back the scope. That's your safe maneuver. Okay,
Yeah.
now you know where you are. Now you can section, advance, and then try again. Good. So now it looks much better, right?
Yeah.
So go ahead, and what do you see right now?
So this is the portal confluence,
Okay.
and yeah,
So this is portal vein.
yeah.
The other thing to notice here is that it looks a bit enlarged. You know, that's there may be some hypertension situation going on.
So
What about this? This structure here.
this seems like this is again a vascular structure. I think we put a Doppler flow last time, and it came
Okay.
out no.
So what's between the portal vein? Try and get this into the middle.
Yeah.
How would you?
Yeah, I'll pull back the scope a bit.
Okay.
Move the big wheel to my
Good.
side, and yeah.
And now push forward a tiny bit, and big wheel towards you a tiny bit. There you go. That's
Yes.
better. Okay. So what do you think? What's usually from the bulb between the probe and the portal vein with no flow?
PD. Basically, CVD is expected to come from above. but
Okay. So why don't we
it's
try
quite
and go?
dilated, and
Why don't we go counterclockwise here?
yeah. So it's
Okay. Try and maintain that view. I'm going to turn this off.
yeah.
So push the scope forward.
Yeah.
Relax. Now relax your big wheel away from you. Good. And keep
Yeah.
going counter.
Yeah, so that's probably CVD coming from above, and this looks like a PD to me, which is rotating around the
Well, we
No.
haven't done much rotation. Why don't you follow this counterclockwise
Yeah.
up into the left? Okay, where is that going?
that's going just behind the portal vein.
Okay, keep following it to the left. So keep going counterclockwise.
But it
Keep going counterclockwise. Okay, what is this?
it's gallbladder.
Good. What about the structure that was behind it that went into the liver? Go clockwise again.
Cystic or
Okay.
sure.
Okay, keep going clockwise for a second.
Yeah.
Keep that in view. Good. You have it in view. Keep going clockwise. Keep going clockwise. Keep going clockwise. Okay, what is this? Before we go counterclockwise for a second. What is this structure here? Let me freeze it.
Ampulla or
I don't want you to feel intimidated, okay? This is just the learning process.
Yep.
But let's see here. Pointer. What is
this is pancreatic stent.
Okay, so what is this likely to
PD.
be? Okay.
Yeah.
What do you think is between the probe and the portal vein?
CVD.
Yes.
Yes.
See, sometimes it's really simple and it's in front of you, but we overthink it,
Yeah.
which is okay. I think it's the nervousness of the situation, because I know yesterday you were doing just fine. So let me see that bile duct again.
Mustafa, we are moving to the other room for
Sure.
a bit.
Yeah, please do.
If you see something interesting, just call us and we'll be back with you. Otherwise,
Yeah,
we're just going to be there for a
and
bit.
this is just for educational purposes. So go ahead and okay.
think
So
I'm out again,
lost.
so
So
yeah.
try start all over. Okay, good.
Yeah.
Get in there.
Yeah, that's
Can you take us to the other room, please?
Okay, now go.
Nice view. No. That's going to dipping down. Must be a vessel. Okay, come down, come down, come down, come down. Very nice, very nice, very good. Good. Excellent. Gently keep withdrawing, keep withdrawing, keep withdrawing. Withdrawing. Very nice, very nice. Good. You've probably fallen back.
Nadeem, we are with you.
Okay, excellent. So thank you very much. Let's present the case. Do you want to go back to D1 and demonstrate the pathology?
Am I audible?
Can you hear a bit in the room?
Can you? Is it? Mic on?
So this is a gentleman who had presented with painful jaundice, had an ERCP when the thought was that he had a distal CBD stricture, and he was a stent was placed. So are we in D1?
Yeah, we are.
Good, excellent. So in D1, you hopefully should be able to appreciate what Shah Yusuf is demonstrating CBD with biliary stent in situ. We'll see if, so this is a patient suspected of distal CBD stricture. And what we have found is different from what was initially presented to us. So let's see if we can demonstrate, Shah Yusuf. And do you want to talk us through?
Yeah. So we can see that there is stent in CBD toward the right of the system. We can see it.
Pointer दीजिएगा. Pointer दीजिएगा.
तो थोड़ा सा zoom out करेंगे
Point.
तो we may have better view there. That's better.
It's not moving. Okay, good. So slightly thick-walled CBD containing a stent. Okay, just
With stent in situ. Now we are moving
and
anti-clockwise.
and a small lymph node. So with an anti-clockwise movements. Good, good, good. Keep going. Make sure there's not pressure on node. So relax your tip up. Good, excellent, good.
Now we can see that there is some hyperechoic shadow with acoustic shadow. So we are near the cystic duct area. So this may be a stone near the cystic duct, which may be causing compression, or it may be Mersey syndrome, which is the cause.
So we feel there's this achogenicity with meniscus sign and posterior acoustic shadowing. It seems to be at the site of where the cystic duct is joining in and is coming in. So cystic duct coming in. This is let's just show us the CBD again. Go back where the CBD was with the stent. So CBD, go back to the CBD with the stent. So CBD with the stent, and now just slowly. So anti-clockwise, anti-clockwise, anti-clockwise. You'll see a cystic duct take off, and at the same time you see a stone. So cystic duct taking off. Oh no, that's still CBD. Anti-clockwise there, taking off. Keep going, keep going, keep going, keep going. Anti-clockwise. There it looks like it's probably within the CBD. But it's right where the cystic duct is taking off. Anti-clockwise, 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 anti-clockwise. Go all the way to the, so follow the cystic duct and go toward the gallbladder. Very nice, very nice, very nice. So, and then do you want to just show us the distal CBD where there was a suspicion of the stricture? So it's probably the stone at the junction of where the CBD, cystic duct joins the CBD. Okay, just take us toward the distal CBD.
So, Nadeem,
Ji sir.
For you to have picked up a stone here, I assume they have asked for an EUS because this compression is at a lower level in the CBD rather than where you generally see it.
Correct.
Because, and the other problem that I've been told is that there's a elevated CA199 as well. Is that correct?
Yes, it's not remarkable. It's, how much is it? 195.
Oh, 195
Is it very high?
well, it's, yeah.
Okay. Fine. So we are now going toward the distal CBD
not the
clockwise.
level which can be ignored or not.
Yep. Keep going, keep going, keep going, keep going, keep going, keep going, keep going. So for the benefits of delegates in the room, I believe that CA99 is helpful if it's elevated, but patient is not jaundice at index presentation, or CA99 is normal and patient is jaundiced. We know a group of patients who would actually not make any CA99, and CA99 will remain normal despite an underlying malignant process. But I think you have to have a suspicion when CA99 is elevated in somebody where we had demonstrated a distal CBD stricture on cholangiogram and ERCP. We have to have a very high suspicion of an underlying cholangio or a pancreatic cancer. On the CT scan, there was no mass lesion. So, okay, we want to see some EUS images. Shah Yusuf. Coupling, coupling, coupling. Again, another important message for the delegates. So ERCP is all about position, position, position. And EUS is all about coupling, coupling, coupling. So you need to maintain coupling. Another thing, very important, that should be your takeaway message from this, at least last 2-3 days, is try not to look at the endoscopic views. I know as an endoscopist, we all have this inherent ability to, and we want to look at the endoscopic images. But for EUS, you actually have to blindfold or go colorblind and entirely focus on the EUS images unless and until you actually have to. So if you're going from sort of GOJ into the stomach or from stomach into the duodenum, then yes, okay. So,
PD.
okay, so that's PD. Is that PD? Okay, so portal vein, PD, and CBD with a stent. And now, just to mention, when we were in the stomach, the pancreatic parenchyma was unremarkable. There was slight coarseness, but apart from this, no focal mass lesion seen. And CBD, PD was not dilated, peripheral to the stricture, suspected stricture in the distal CBD. So again, and to some extent, that was reassuring. Okay, now follow it, please. Follow it toward the. We want to take us toward the ampulla. Shows the ampulla. Keep going, clockwise, 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 clockwise. Clockwise, keep going, 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 all the way, all the way. In this position, sometimes you do actually have to do a bit of a talk. Go clockwise, clockwise, clockwise. Keep going, 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 all the way. We have to start seeing the duodenal lumen and air there. Good. So throughout scanning it all the way to the distal this CBD, we cannot truly appreciate any focal mass lesion. Okay, and then go again. So you keep scanning in all the plan. So sir, what's your take on it? I mean, we haven't identified. I mean, the thickness of the duct is.
No, I think with what you've shown is we need to put a spike and take this stone off and then see what happens. That's what we would do.
Yeah.
Maybe the patient is already anesthetized, and so
Suction,
we can actually
suction,
change
suction.
the scope and put the ERCP scope
Suction,
and go
suction,
in
suction, suction,
and
suction.
confirm what we have seen.
So
we'll be moving away from you, Nadeem. Thank you so much.
Yes, sir.
And you can we need to have you here again as well for the rectal US. You have something
Yep,
prepared?
I'll come back to the room.
Okay, great.
Thank you.
Okay, thank you.
Excellent.
Thank
Good.
you.
Very good. Well done. Well done. Good. Do you want to say
Mustafa?
anything else?
Should we see D2 again?
Can we go to the other
Yeah,
room?
very happy with that. I think it's fine. We can see that. Yeah, let's just go in clockwise, clockwise. Oh, good.
Nadeem has made a good point.
Very nice, very nice.
There's some echogenic shadowing, and I'm going to go clockwise to see if I can see the PD. So this is bile duct.
But we don't
The
see
top
that
one. The
stent.
top. Yeah, this is bile duct. Usually if you have bile duct in Divisum, if you go clockwise, you would expect to see the stent. I think part of it is the changes. I just fell back. But there's your stent now.
Yeah, briefly.
Yeah, you can. There's your bile duct, and if you go clockwise, you would expect to see the stent. But it's right there at the top. So I'm going to maintain that view, and here it is coming. Isko freeze kar dena. So now we have our stent
The top.
coming into the duodenal lumen and going into the pancreas. When I unfreeze it and spin here, I'm going to take the Doppler off. And you will see that you see the PD stent going across the duodenal lumen into the pancreatic duct. Theoretically, if I go 90 degrees counterclockwise, I should see bile duct, and there's your bile duct right there. The ventral duct below, bile duct, and if I have my bile duct, I go 90 degrees clockwise. That's for Divisum. You should see the stent here, which earlier we did. Right here and then there. So 90 degrees clockwise, you see PD, and if you go 90 from the stent, if you go 90 degrees counterclockwise, you see bile duct. So the two ways to look for Divisum. From D2, what you do is you pull back, you have your view, you have the ventral duct. Everything's somewhat compressed here, but ventral duct and bile duct. Once you have the bile duct, you go 90 degrees clockwise. So I'm going clockwise, and now you see the stent there.
Yes.
And if you go 90 degrees counterclockwise from the stent, you'll go back to bile duct. The second way to look for DVSIM, which we saw as soon as we went off camera, is once you have your bile duct in view and you follow it, you're following it towards the papilla. Let's see if I can see it. You will see the stent below it to the right. You can clearly see the stent here. It's pretty obvious, right? And you'll see that the bile duct will come down this way towards papilla, but the pancreatic duct stent will go up this way towards the minor papilla. So in DVSIM, the pancreatic duct will not turn around and join the bile duct. It'll keep going off to the right as the bile duct comes down. And this may be the ventral duct. So as I go clockwise, the bile duct goes down towards the major papilla, but our stent keeps going off to the right because that's towards the minor papilla. So the minor papilla from the bulb will be more to the right of the screen, and the major papilla will be more to the left of the screen. And as you go counterclockwise from the major papilla, you can see the bile duct, you follow it up. As you go clockwise, the bile duct dips down into the ventral pancreas, which is dark, and the PD goes back up all the way. As I keep going clockwise, it's going to keep going up to that wall, which is the duodenal wall for DVSIM. The other thing that I wanted to show here, the gallbladder is intact, but slightly like full, but that's okay, is just the chronic panc changes obviously are pretty profound. He does have some echogenic debris and sludge in the what looks like in the unsnip process. And here's your pancreatic duct. You can see, and this is not uncommon in patients who have EUS after a PD stent, that the duct will be dilated and there will be debris inside, but the patient is, that's the stent. You can see how atrophic this gland is.
So what we wanted to, we've been discussing, and I want your view, Mustafa, is that when you're diagnosing autoimmune pancreatitis on EUS in a person who's got elevated IgG4, and if there are any issues, or what would be your what threshold you have for doing a pancreatic biopsy?
Yeah. So honestly, I think IGG4 gets checked way too much, but that's just part of the workup. If I was to do it, in my personal opinion, and this is not necessarily based on data, it's very hard to differentiate AIP versus pancreatitis or chronic pancreatitis or acute pancreatitis from other causes. Sometimes you will see, and I have one patient like that, where you have profound changes in the body and tail, and the head is completely spared. And there's almost like a hypoechoic or anechoic rim of fluid around the body tail area. So there the MRI was also suggestive, so that was, confirming the MRI findings. Oftentimes they may have acute pancreatitis, and so you can't really differentiate what's going on. And the other main presentation that we see would be if you have a mass-like presentation in elderly patients, where it's more of a diffuse type of a mass, not as clear-cut boundaries, and you take specimens, and the pathologist, if you have rows, will say, I see inflammation but no definitive cancer cells, and those patients, generally speaking, one has to be suspicious. But other than that, there's nothing really that to me will stand out oftentimes. And in those mass type findings, when you do the biopsy and they do IgG stains, they say IgG4 stains, they say they're elevated. In this type of a patient, I would personally favor not sampling him right now. The neck head area is somewhat atrophic. I wouldn't biopsy that. You could consider biopsying this area, but it's going to be a lot of inflammation. And I think with this 1.5 times the upper limit normal, I would just leave that alone and not have I would not have a low threshold for biopsying. Any questions or comments on that?
Mustafa, what about biopsying? Anything? I mean, when you're biopsying the pancreas.
Yes, so we had a case.
What needle you prefer, and
we had a Absolutely. We had a case of suspected autoimmune the other day where what we did was core needle for sure, and we have the acquire here, so I use that. Generally, I would try and go wherever I feel my trajectory will give me the most tissue. So here, I would be worried that this neck area is atrophic, and we have a stent. So oftentimes when you have good parenchyma here, I would try and sort of target in this trajectory down towards the neck to get a core specimen. If that, in this case, isn't really the ideal position, there's more fullness towards the body, so we could certainly go this way into the right here into the parenchyma and do like about 6 to 8 actuations, and then I would also consider going into the head of the pancreas. Typically, if I have a good area, especially in the neck, I may just stick to that. Otherwise, I may switch my location and go to the head.
Yeah.
Obviously, if you have a mass-like lesion, then you go for that area.
Yeah, Mustafa, I think for autoimmune pancreatitis, if the symptoms are there and IgG4 are positive and everything is pointing towards that, that's a relatively easier decision, but not every case presents like that.
Yeah.
So the IgG4 is negative and you do a imaging, there's some suspicious of that, like it's a bulky. If it all looks like it's bulky and they say what they call a sausage-shaped pancreas or a very bulky pancreas, and even though they have IgG4 negative, in those cases, you can treat as such, even like IgG4 negative type 2. So the problem really is like which are borderline cases. What is the threshold to proceed with the pancreas biopsy and how much that is going to help? Before pancreas biopsy, some people may just do the biopsy of the ampulla itself and send that for IgG4 staining or plasma cell staining. If that is suggestive of that, that's present, you still may treat as such. On EUS, autoimmune pancreatitis, yes, burnt out autoimmune pancreatitis, recurrent pancreatitis can have features of chronic pancreatitis, but in the early stages, it would look enlarged pancreas. There may be some fuzziness at the edges, but it would not be like atrophic in one area and the rest of the pancreas is very bulky. Usually the whole pancreas looks like that. And bottom line comes is like if you really have to do a biopsy, find the best place, be it stomach, be it duodenum, where you're gonna be far away from the main pancreatic duct. Okay, that's the main thing, and try to minimize the number of passes, be it 1 or 2, but do not go close to the pancreatic duct. That would be the main thing.
Yep. And also
all of those, but especially the pancreas which does not have a cancer.
Yeah.
Okay. Any from any scenario, but when it's a cancer, you're gonna get away even if you stick a PD. But any other situation, stay away from the pancreatic duct to prevent the leak. So for me, Mustafa, I don't know what your, I think you maybe same way to going for the biopsy of the pancreas just to diagnose autoimmune pancreatitis is a very high threshold.
Yes. I mean, the clinical picture has to fit.
Yeah.
And in this type of patient, the other thing you have to worry about is collaterals. You see all these vessels, and so sometimes you put the sheath out and you think that there's no vessel there. You have to really relax. If you're compressing a vessel like this and there's nothing there, you can reassure yourself there's nothing, and then when you put the big wheel away from you, you can see these vessels. So you may inadvertently be compressing a vessel that you're going through, and afterwards you may cause bleeding, and these are high pressure veins. So you have to be careful. So again, having a high threshold where you know that the risk of adverse events will be higher too.
Thank you, Dr. Mustafa.
Okay.
So we will be taking over
Okay. You want to do
the stage to Dr.
mediastinum?
Nadeem. He's giving a talk on rectal ERCP.
Oh. You want to go to that? You want to go to the rectal
yeah,
US?
I'll just quick sweep through
Okay,
the
good. Yeah.
mediastinum and then
Okay.
Sorry, he's giving a talk on rectal EUS. My bad.
Good texting.